Hello, everyone, and welcome to today's World AIDS Day Pride Talks webinar, Ending AIDS by 2030, a reality check. We are happy to have you with us today. My name is Alan Kuyakos, and I am the fundraising coordinator at the Stephen Lewis Foundation. Before we jump into our panel discussion, I have a few things to cover. First of all, we welcome you to use the chat today to introduce yourselves and to engage in the conversation. We recommend that you select everyone from the drop-down menu so that everyone in attendance can see your conversations. Today's event is 1 hour. We'll listen to our amazing panelists for the first 50 minutes, and we will open up the space for a Q&A session in the last 10 minutes. We encourage you to submit questions through the Q&A feature during the event. Now, as we get started, I would like to start with our land acknowledgement. As an organization based in Canada, the Stephen Lewis Foundation acknowledges that our presence here is a direct outcome of the settler colonial state whose policies of expulsion from the land and cultural genocide continue to impact Indigenous communities today. I am joining the event today from the offices of the Stephen Lewis Foundation, which are located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. The Stephen Lewis Foundation acknowledges that oppressive and inequitable socio-economic and political systems in Canada continue to perpetuate a legacy of racism, intergenerational trauma, and structural inequality, and that this legacy is directly linked to the disproportionate impact of HIV on Indigenous communities within Canada. We at the Stephen Lewis Foundation are committed to the principles of social justice, equality, and solidarity with our community-led partners as they face the continued effects of colonialism. Consistent with those values, the SLF is undertaking a journey of ongoing learning, reflection, relationship building, and solidarity with Indigenous communities in Canada. Today's event, Ending AIDS by 2030, a reality check, is an attempt to understand the realities on ground in HIV and AIDS response and to identify the barriers existing that needs to be addressed to achieve this goal of ending AIDS. This year's theme for World AIDS Day is Let Communities Lead. In honor of World AIDS Day, we, the SLF, have put together a video for you. Please enjoy.
"20 years ago, communities across sub-Saharan Africa faced the devastating impacts of HIV and AIDS. Today, we celebrate the progress that has been achieved to save and improve the lives of so many people around the world and recognize the central role communities play in leading the way. This World AIDS Day, we echo the global theme, Let Communities Lead, acknowledging that true progress is driven by the strength and resilience of those at the forefront of the fight against AIDS. 20 years ago, 3.2 million people in sub-Saharan Africa acquired HIV. Today, that number has been reduced by 80%, a testament to the impact of community-led initiatives and increased access to antiretroviral treatment. These statistics represent real people, children growing up with parents, young women living free from HIV, and families thriving with the support they need. Communities are leading the way. As we celebrate progress, we must also acknowledge the work ahead. Inequities persist, fueled by racism, colonialism, gender inequality, homophobia, and transphobia. Let communities lead is not just the theme for one day, it is a call to action. Progress has not been equal for all. Community-led organizations are on the front lines, working to address the inequities that persist. And so today, let us recommit to the work ahead. To end the HIV epidemic requires that all of us, every one of us, play our part in ending discrimination and realizing human rights for all people. Led by the strength and expertise of communities, together we can achieve a world free from AIDS.
In an environment of heightened homophobia and transphobia, there is an urgent need to understand the inequalities of prevention, care, and treatment that exists in HIV and AIDS response. Now, I would like to introduce our moderator and the panelists for the discussion today. Kenita is the co-founder and executive director of the Eastern Caribbean Alliance for Diversity and Equality. They have been a human rights advocate for over 18 years. Welcome, Kenita. Racquel has over 20 years combined experience in HIV health promotion and education, clinical management, and community development work in the Caribbean, North America, and Norway, and has been an activist around issues of social justice and health equity and inclusion. Racquel is currently the clinical lead at Casey House here in Toronto. Samuel is the director of Mamboleo Peer Empowerment Group, MPEG, a human rights activist and defender based in Kenya. Thank you all for joining us today. A warm welcome. I wish you all an empowering and thought-provoking discussion. Over to you, Kenita.
Thank you so very much. Annual AIDS Day, it's really one of those days that impact us in many ways, whether it is from just community, in terms of chosen family, in terms of general population. We know persons whose lives have been lost through this pandemic at some point or the other. So this day, we do more than one thing. It's not just a day to remember that the pandemic is still alive. It's also a day where we celebrate those we have lost, and we continue to support those that are still surviving. It's really an honor to be able to represent the Eastern Caribbean Alliance for Diversity and Equality here this morning. But it is even more of an honor to have our colleagues here, Racquel and Samuel, who will be sharing with us so much more of their work, what's happening with their organization, but even as individuals on the front line. So I'm not gonna take any more time. I'm gonna send it straight over to Racquel to give us a little more about the work you have been doing and what World AIDS Day means to you. I'm gonna start off there.
Good morning, everyone, and thank you, Kenita. When I was asked to join this panel this morning, I had to reflect on when I got started in this work, and it actually happened when I was living in Jamaica as a young teenager, volunteering with the Red Cross at 16 years old. This was when I became first aware of what HIV was in the early 90s. So we began to lose people. I was a volunteer helping with disaster recovery and Meals on Wheels programs, and I was introduced to the peer education model. So I went out into schools, and when I got to university, I was also an ambassador for the Red Cross through their sexual health program. And that's also when I started going to funerals of my peers. So this work is not a job, it's a calling, it's a passion, it's a way of life for me, because I've been doing this longer than I've been doing anything else. And it's actually what inspired me to get involved when I migrated to Canada as well, working at Canada's first and only HIV hospital, Katie House here in Toronto, and leading a team of clinicians to support folks living with and affected by HIV. And it's something that I don't know how not to do. I also I still volunteer. I'm a board chair of an AIDS service organization in Peel. And so, this day means a day of reflection, a day of remembering our resilience as people in the fight, people, from our communities. And it's a reminder that we still have so much work to do. So that's what World AIDS Day means to me.
Definitely. And we are hearing you and we are feeling you on this point. And Samuel, over to you. Same question as well. I mean, we have a lot of questions, but I think this one is dear to understand.
Yeah, thank you so much. Good morning and good evening. It's an opportunity that is rare to actually even celebrate the life that we have had as queer folks or members of the LGBTI community. And just as my colleague is saying, today actually I was closing out the peer educators training today, and it reminded me that I started there as a peer educator to be able to give information, to share healthy information that is true and can be able to save life. So it's also reminded me that it is very important to continue with this journey and to be able to let more people understand and get more information. That is what it means to me. Thank you so much.
And as we sit and I thinking about just what you said, it means that we all have been in service of community. We have been in a place where we have been very selfless, giving to community, but it has also been a selfish move as well, because we want them to be in a good place that we can do other things as well with them. And just hoping that they can listen. And although this pandemic is not just a LGBT issue, it is a society issue. I think a lot of people tend to deflect where the blame sits. So right about now, Samuel, I'll probably come back to you. What is the availability of health care services for the LGBT individuals in your country? And, how are they different from what is provided to the general society compared to what LGBT persons are able to access?
Thank you so much. For the general population, we have the usual normal health facilities, but also what is available for the members of the LGBTI persons, we call them DICE or drop-in centers. Our community has actually improved because we used to have very minimal package for the LGBTI persons. But now as communities are growing, we're also finding that from level 2, level 3 clinics are coming up, being implemented, designed by the community. And by this means that they can be able to render what they really want to see in these facilities, apart from what is being offered with other general facilities. Because we all know the general facilities are always packed, they are always full. Some of them are really dirty, and some have all those comprehensive package that the LGBTI community would wish to see. And some of our clinics have actually become safe spaces. Like in the general facility, you can't just go and hang out. You cannot. But within our clinics, you can come, hang out, use Wi-Fi, be able to talk to people, because we have seen this has really helped removing the hospital part of our clinics from people's mind, that you can only come to DICE just to seek that one aspect. But when you come, you can be able even to be mentally okay, and because you can be able to talk to people and you can actually get yourself to have what you want to have. That is what is available.
And this is certainly sounding like progress, because you're saying before it didn't, and now you have options. And even as the options pop up, we still need to look at what in the options are still available. Because is it inclusive in terms of language, in terms of not just they're getting there, but so we definitely, as before I go to Racquel, one of the questions I want you to think about, and I'll come back to you for, it is what is the availability of HIV prevention treatment? And you're talking about not just condoms and lubes, but also thinking about PrEP and ARTs as well in your community for LGBT persons. But before you answer that, Racquel, tell us, do you think the HIV response in Canada is equitable? I said that and I saw the look on your face and I'm like, but also as you're answering that, what are some of the barriers that continue to exist as well?
I thought long and hard about this question because I had to think about my perspective. And being in Canada, Canada is a very large country and it's a very diverse country. It's also where, in terms of LGBT people who migrate to Canada, like myself, we land generally in Ontario most of the time, specifically in Toronto, which is a very large city. But if you were someone who landed in Manitoba or Winnipeg or, the Northern Territories, their experience would be very different from what I'm going to, share about Ontario specifically. I've been living and working in this province of Ontario for 15 years, specifically in healthcare, general primary care, or in a specific HIV organization, so an AIDS service organization, but primarily in primary care, in community health center spaces, or now in an HIV hospital. And I don't think the response has been equitable, especially for Black and Indigenous folks. We have a provincial strategy in Ontario for priority populations. So we have a strategy for men who have sex with men called the Gay Men Sexual Health Initiative. We have one for the African Caribbean Black population, the ACHO strategy, African Caribbean Council on HIV AIDS in Ontario. And we have one for women, the Y strategy, Women and HIV Initiative. We also have some strategies for people who inject drugs. And it is government funded through the Ministry of Health, but I don't think those strategies exist for other provinces across Canada. And that is something that is lacking. I know that Canada is a big funder for UNAIDS, but in terms of the amount of money that we provide to support initiatives internationally and locally, it is not enough for the need currently. Folks have been disproportionately affected by COVID. So when we think about care, we have to think about all the basic needs, all the social determinants of health. Yes, we have free healthcare if you are a landed immigrant and you have immigration status in this country. But if you don't have papers, you're not going to have the same opportunities to access care and treatment. So it really depends on where you live in this country, your immigration status, and the color of your skin. That's because there is racism in healthcare, and that is what actually drew me to work in this field. Because I came as a refugee to this country, being queer myself, and my experience was not favorable when I walked in with my immigration papers, which was interim federal health care for refugee claimants. So until I got my Ontario provincial health plan, then my experience became very different. So it really depends. We also have seen where we've actually taken steps backwards when we're looking at health education and sexual health information for a youth, the sexual health curriculum changed in 2019, where now it requires school boards to allow parents to exempt children from teaching on human development and sexual health. Now, concepts of like gender identity, which was previously taught in grade 6, is now being taught in grade 8. So even just basic information is not being shared with youth, I think, in a timely manner. And that is the foundation of their experience when they even, become sexually active. What are their options in terms of knowledge for getting condoms? And, we're a first world country, but I think there's definitely some gaps. Definitely some gaps.
But Racquel, as you spoke about that, and you're thinking about the gaps, do you think at this point, the key populations in Canada are receiving the support they require? And do you think that the availability and accessibility of HIV prevention and treatment in Canada is widely available? Because I think that's what it comes down to. Like, these two are kind of intertwined. Is there support and is there accessibility? And I think that's the big part, because political leaders might say it's all available. If it is available, is it accessible? And that's two different things.
It isn't available in every province equally, and it is not available depending on who you are. As I said, if you're Black and Indigenous, you sometimes have one option, which is maybe 50 miles away. And if you don't have a car, how are you going to even get the condoms, the lube, PrEP? And if you live on reserve as an Indigenous person, these are limited factors to accessible treatment and care. There's sometimes no healthcare provider available every day on Indigenous reserves. So you don't have the same access as you would if you lived in, for example, Toronto, if you live in Saskatchewan. So Saskatoon, it is not the same. We have to think about the cost of ARTs. It's very expensive. The cost of PrEP runs between $250 to $1,000 Canadian every month. And if you are living hand to mouth, you can't afford that. Yes, there is coverage for youth under 24, people over 65 years old. If you're on social assistance, Ontario Works, Ontario Disability. Yes, if you have a drug plan with your employer, yes, you can have access to those treatments and prevention treatment technologies. But if you are, a worker who doesn't earn a lot of money, then you're exempt from this access. So there are definitely issues. These are like the fine prints. When you say, oh, there's healthcare and it's free in Canada, it's free for some, and read the fine print. So these are the fine print issues that most people don't know about.
But then does that translate into the supports for key populations? Because, with the whole health mandate, how do key populations fall in this? Where is the support systems, the support services?
I think there's quite a bit of support for men who have sex with men. So we have private clinics, like PrEP clinics here in Toronto, specifying their target population are men who have sex with men, but we don't have the same for women. We don't have the same for example, Black communities. And if you think about intersectional considerations, if I'm Black and queer, will I feel safe going into a Black institution because of homophobia? Especially from countries like where I come from, where it is still illegal to be gay. Will you want to disclose that aspect of your identity You may not
Mhm.
feel safe. So it's very nuanced. We
Yeah.
don't have enough services for women generally. Women who live with HIV, queer women, bi women, where folks are culturally competent. We're seeing a limit also around healthcare providers who are culturally competent and trained in HIV treatment. Our specialists are very, they're located like in one hospital in not in every city. A lot of people will travel over an hour or two sometimes to get to their HIV specialist. And there's,
Yeah.
wait times, or they have to fly somewhere else to find someone who understands their full identity. So it's
Yeah.
challenging for some populations.
Definitely, we could see that, and we definitely know the economical standards of everyone is different. And even if Canada is, in the global north, they have their challenges as well. And sometimes maybe us who sit in the global south do not necessarily see it because we just think about all the opportunities and not necessarily any of the challenges. But Samuel, we're going to take it right back to you. You have had some time to think about this question. But, one of the things I think in Racquel speaking to us, I just realized is like asking you what is the availability of HIV prevention and treatment, in for the LGBT community. I also want you to think about not just availability, but accessibility as well. So over to you.
Yeah, I am just looking at those two, accessibility and availability, coming from Africa and Kenya in particular. The prevention commodities, the treatment commodities are rare. I can tell you for sure. One, because the procurement processes, we know like in Kenya, the health department has been devolved. So things come from the national government trickling down to the counties, and it takes ages to reach that one person to get the ART. Can tell you for sure, right now we don't actually have lubricants. We don't have those at the moment. And I know some sites have stayed more than 4 months. What does that mean when a community site does not have commodities for its beneficiaries? It's like massacre. Like, how do you expect the key population or the LGBTI persons to survive without drugs, to survive without the prevention commodities? It takes years. And when it comes, probably because they have stayed in the store, when you start looking at the expiring date, it only gives you 4 months or 8 months, knowing that fully well that after 6 months, now there will be scarcity of the same commodity that you've been waiting for years. So for us, the availability and the accessibility of them is new, because you can have them at the moment, then all of a sudden you cannot be able to access, because the government will give priorities to the government facilities first before you get your commodities as community facilities. So you also see it becomes very hard to even run clinics when the availability and commodities are not available. Yeah, because again, you cannot be able to go and procure your own drugs, because you know how that trickles down, because we also have a facility that is a satellite facility for the government. You cannot procure your own drugs. You have to wait the government to be able to procure those drugs for you. And it takes ages to actually have the commodities with us.
Right. And I think this is something that's always the query, because even as you think about Canada, Kenya, I can take into consideration the Caribbean, which is where I'm sitting. And one of the things we always look at is even the access to buying the drugs. It's not just, even like condoms, accessibility for free condoms. to be able to do the outreach is also problematic at times for the LGBT organizations, depending on what relationship you have with your national AIDS program, you know. And this is something that, whether through Global Fund or any other funder, our countries are committing to working with key populations. But key population is not at the center of the response, not the way that they should be, you know. So it's one that it is still amazing that the LGBT community still gets blamed for, especially the men, for HIV even in 2023. And yet we're still struggling so many years later, having this pandemic almost outlive us 20 plus years, and we still feels like we are still in year one trying to understand the pandemic in itself. But for both of you, the theme for this year's World AIDS Day is remember and commit. What does commitment look like for your government, your supporters, your community-led organizations, and to some extent, even the funders that you have as well? What would it look like in terms of actionable items? You know, and I think y'all can take this in many different, so I see Racquel, you look like you're ready to hit that question running, while Samuel needs to put down some thoughts together. So go ahead.
Well, I think, you know, most of the work being done in Canada is government funded, right? Through the Ministry of Health, branch of the ministry in Ontario is called the AIDS Bureau. So that funding generally covers the salaries of staff and the office, you know, some supplies if you're running workshops, etc. But when you think about the needs of the clients, we cannot provide anything but information. And, you know, there's no medication that's covered. There's no housing support. There's no meals. There's no, all the basic needs. There's no funding for that, especially around medication and food. Sometimes those are the things that come up as the most important needs. And that's why a lot of people living with HIV, even if they're able to work, they have to think twice, because they're like, if I'm on the Ontario Disability plan, then my drugs are covered. Then, you know, I may get housing subsidies, etc. And it being an episodic illness, that's what we find. A lot of people have to resort to being on disability to be able to ensure that these things are covered. Because if they do work, then the money is clawed back, and these things sometimes are a little bit more challenging to access. All right, there's a lot of red tape and proving income and filing your taxes, etc. What I would love to see is a more intersectional, anti-oppressive approach to the fight against HIV from our government. Looking back at some of the strategies that have worked in the past around advocacy, around especially education, because I'm realizing a lot of people today, if you walk on the street and you ask people, what is HIV? Some of them don't know what it means. You ask them, what is AIDS? How do you, you know, do you think you're at risk? You know, some of the basic things 25, 30 years ago that most people knew because it was all over media. You know, it was more visible. Nowadays, we have lost the capacity to understand that people are at risk, and that's why rates are going up, especially among women. Black and Indigenous women in Canada, in some provinces, have some of the highest rates, and it is being acquired through heterosexual relationships. So a commitment looks like more funding from the government to cover especially the cost of medication and other social supports for especially disenfranchised communities. You know, a need for more community-wide educational efforts around prevention, increase in awareness so that stigma can be reduced, because stigma is still a big factor, especially if you think about racialized populations. And looking at normalizing testing, not having to go to particular HIV specific locations for testing, but making sure that that conversation is comfortably shared by your primary care provider. If you go to do your blood work for your diabetes or your high cholesterol, or, just say, hey, would you like to also get tested for all the STIs, including HIV? That is something that a lot of healthcare providers are not comfortable asking or sharing. And even if you're from the LGBT community, you don't feel comfortable asking for that test, depending on the neighborhood you live in this country. Because then you're stigmatized. Oh, you are gay. Oh, or, you're doing things that are putting you at risk that are not favorable. No, you're having sex like everyone else. We need to normalize these conversations. And so I think there should be, especially training healthcare providers, that not be an option in medical school if you want to do probably global health. But it is something that is taught to every nurse to be, doctor to be, that these are things that you should offer your patients and how you can have that conversation comfortably. Those things are not happening in our healthcare system, in our education system today in Canada. It's an option. Everything is an option, and people opt out most of the time.
And, I think you kind of focused a lot on the government part, but also what does that commitment look like in terms of community-led organizations as well?
I think we need to work better together across sectors. So because a lot of the onus is sometimes left on the aid service organizations to build those relationships. And because the AIDS organizations were historically led by LGBTQI plus folks, they're not sometimes welcomed in particular spaces. I'm going to speak specifically about the Black community that I belong to and the work that I have done. We have sometimes reached out to faith-based organizations or educational institutions, and we were not welcomed to partner because of internalized homophobia and transphobia by some of those leaders and gatekeepers. So it is still something that Canadians face, even though we're here in this first world country that is seen as, one of the prime examples, or one of the best places to live. The issues that are in the Caribbean and Africa exist here too. And it's just not as overt. So I think working across sectors, working collaboratively with the people most affected, that has to be, they have to be centered in the work. So the greater and more meaningful engagement of people living with HIV, the folks from the LGBT community, sometimes there's an intersection of those identities, and working with the other systems, the healthcare system, the religious institutions, the education system, and even powers like the judicial system, prisons, etc. We need to work better together because this is an issue that's affecting all of us. The pandemic has, I think, set us backward because we are so isolated for nearly 3 years. The rates have gone up in this country. We just don't see those stats until a year or two later. But the rates are going back up.
Definitely. And technically we're seeing the same thing in the Caribbean, but I'll share a little glimpse of the Caribbean in 2 minutes. But Samuel, please take us through your side. What does the commitment look like? Government, supporters, community-led organizations as well.
I think I want to reiterate and support Racquel, because when we're talking about community and the civil society, I think it is time we push out some of the agendas, advocacy agenda, to change a lot of policies, especially in Kenya. to be able to have policies that are favorable, policies that are remove the barriers to HIV and AIDS. And we have also to make sure that the government commits to all these policies, and not just committing, but also become very accountable, both to money and to the people that they serve. One of the beauty of our constitution, especially in Kenya, is the fundamental rights, where we have rights to seek medical to the highest attainable point. That is a commitment that we would want to see enforced, not only that people will have other facilities, but the government can be able to enforce that, and they become accountable to the funds that are trickled to the facilities, and so that they can be able to help the beneficiaries. Something else, when you ask me about commitment, I just think about decriminalization, especially in what is happening within the East African region, that because of criminalized population, the key population is criminalized population, they are not even able to get services. But if we could decriminalize and push the government to do this, and the CSOs within the fraternities of Kenya put that as an agenda to not only look at people because of their sexual orientation, their gender, their religion, but look at people as human beings, then that will be a very good commitment to the government and from the civil societies. Thank you.
It is certainly a move, and I think I can echo the sentiments just the same, particularly for Caribbean region, that most of our funding is actually through Global Fund for the HIV programs. I don't even think we have the budget in this region to be able to do this alone. So, something Canada have, probably Canada is giving us money also to do HIV programs as well. But when we look at the numbers, we had to change the manner in which data collection was being done, because it was not really telling the story. It's like, if you remember HIV data representation back in the day, it used to be male and female, full stop. There was no other disaggregation to give us where is it, until we started, getting where are the hotspots, which communities are they in. And, each year we supposed to improve what we have done before, not roll back. And I think this is the challenge, because when you have been sitting at the front line for 10, 15, 20 years, 25 years, 30 years, it means that you have seen where things were and you've seen where they are now, and you feel like we have just gone in a loop. We're back at the beginning, but we are so back at the beginning that the sensitization and the education that's required for our young people have dropped through the cracks. Because the older ones are saying, oh, we know about AIDS already. Okay, kudos. We did a lot of work between 1985 and 2012. What happened beyond that? The gaps in education started falling because people tuned out. As people were dying less and they can now live with this disease, people have tuned out. And so one thing that I keep hearing both of you say is that we need to move. We need to change how we are doing things. We need to work better together. We need to actually move forward and not roll back. And so the last question before we open it for questions from persons attending: what needs to change now to make ending AIDS by 2030 a reality?
So many things. I mean, 2030 is only 7 years, not even 7, because
so do you want to list 5 or 10?
We don't have much time. 2030 is the target for us to end HIV/AIDS in our lifetime, but that's 6 years away. So not even, it's 2024 next month. 2024.
Yeah, but you have the whole year to go through.
I know, but it's
Okay, 6.5 years.
Okay, let's say 7. I mean, some of the structural and systemic issues that are affecting the priority populations in this country is not going to change in that time. And as you said, Kenita, we have not been prioritizing mass media education for the general population the way we used to 10, 15 years ago. A lot of the posters around, PEP and PrEP and the targeted communications are really focused on gay white men in this country. We don't have the same approach to women. We don't have the same approach to indigenous populations. We don't have the same approach to people who inject drugs, as we see the focus still being placed on gay white men who have sex with men. So I think we need to think about other communication strategies around HIV prevention, around care. We also need to normalize HIV testing and not have people travel so far to get a test. It needs to be available to everyone, despite your neighborhood, despite the province you live in. We need to train healthcare providers to have these conversations in culturally competent ways. You think about how diverse Canada is. Most information is only available in English, maybe French, even though we're supposed to be, a country that speaks both languages. Francophone people don't have the same access as English speakers in this country, much less if you speak, Tree or Tigrinya or, Patois or any other language or indigenous languages. There's not any written information available. And we think about, the availability of self-testing kits. That is not something that most people even know exists today, still in Canada. Right? We see that available in certain neighborhoods, in certain organizations that may be in partnership with an academic institution doing research, where that is rolled out as part of the strategy around HIV prevention. But if you walk into a suburban healthcare facility and ask them if, do you know about HIV self-testing kits? They don't know that. I'm still having those conversations even in my own network here in Toronto with my friends and family who are not working in the sector. They did not know that you can actually do HIV testing in your home. That's more available in the US, but not in Canada. So we have a lot of work to do. There's been a general decline in traditional grassroots education, and it's evident in the increase of the rates that are going up for especially Black and Indigenous people in this country. We're representing about 25% of all the new infection rates, yet we're less than 4% of the general population as Black people. African Caribbean Black people represent less than 4%. But of all the new infection rates, we're nearly 25% of all new infection rates still today.
Right.
So that is evident that there's still work to do.
Definitely. And we definitely know the work done. It's a sad thing that we feel that the work done so far is still insufficient. We have not gotten to that place where we could say we at least comfortable with where we are. And HIV pandemic is not something to be comfortable with, But I think one of the things that definitely has stalled our progress is, earlier on, one of you said it, around sex It's normal to have sex. Yet it is still abnormal to talk about sex. And so that is creating a loop for us, a gap, a challenge in how do you not talk about the thing that you actually enjoy doing.
But it's also not safe for women and girls to even not, you know, there's issues with consent to have sex. So,
Correct.
Gender-based violence is a serious issue that we also need to tackle when we're talking about HIV rates for women and girls in this country and all over the world. Intimate partner violence increased during the pandemic, 7-fold in certain data researches, where it's just gotten so much worse. So that is also what has impacted the rates for women and girls.
Definitely. And we saw that in so many countries. And one of the questions was it really, it increased it, or did it actually, we were able to stop and pay attention to the data? So that's really the question. Did it increase, or is it that it's there, but we did not pay sufficient attention because we're multitasking? But with planes being shut down, travel being changed, we had to sit down and read the reports and take a reality check on that situation.
Jobs being lost, stress on women to be the caretakers, the rearers of families, still also working remotely, still taking care of the children, because a lot of the daycare centers are actually closed for quite some time. So the stress level in homes just really, really increased. And these are things we have to think about. And also mental health and addictions, those rates have also increased a lot. The substance use issues, poverty, suicide, all of these issues have to be discussed.
Definitely. And so we'll take this question. Samuel, it's your turn to take us through what needs to change now to make ending AIDS by 2013 a reality for you.
What I think, and I think, Kenita, you've mentioned it, is like we need to unlearn. We need to unlearn what we had learned so that it changes everything, because we've been doing HIV programming for the last 20 years or so. So we need to, because we are trying to change even attitudes, we are trying to look at data, we're trying to see what is it that we are not doing, because we need to unlearn, so then we learn new strategies of how to tackle HIV. Looking like in Kenyan perspective, is the first time you go as an LGBTI person and you're probably feminine and you go to a clinic, and the first thing people do, or the healthcare workers do, is look at you twice, not even asking you whether you have that letter or what is your problem. They look at you twice and they call each other. We need to change that. You see, first of all, you have to treat people as human. I had talked about decriminalization and making sure that we know everyone is human. So when you go to a facility, let's say, for example, a dispensary, because some of our LGBT people are coming from the rural areas, and you're scared to go to the facility because the receptionist is probably your relative. You don't want to go to those CCC sites because one of the clinicians or the nurses there is probably your auntie. You travel also away to go and seek services. We need to change our attitudes so that we look at HIV in a new dimension. We look at when a young person comes to your clinic and he's showing anal wax, you don't have to put your white coat and start running, calling other doctors to come and see. first we take care of our medics because they also take care of us, that we take them and sensitize them, change their attitude, that every human being is supposed to be treated first. And that morality policing where we are putting, especially in Kenya, you're putting your religion first, and yet you're a medic, then that becomes a problem. Looking at the laws in Kenya, they don't favor the LGBTI community. Right now, we are having bills coming in parliament up and down every day, just to make sure that they are actually fencing the need of that LGBTI person to get better services. How do we get better? How do we even end HIV, whereas our attitudes are bad, whereas we have unsensitized healthcare workers? We have to unlearn and start from a point of treating everyone as a human being. Thank you, Kenita.
You know, it really gives the kudos, and I know we are coming pretty close to time. But we do have two questions here that I'm just gonna flash in. What are the current organizations doing about incorporating mental health as a bio-behavior service towards LGBT plus community, and working with or for the community? And I think that one, Racquel, you kind of touched on it in terms of thinking about how mental health came up. But more importantly, Samuel, the second question is actually one directed at you. It's saying that they understand that your organization is a partner to the Stephen Lewis Foundation, and how does the support from a partner organization like Stephen Lewis Foundation help you do your work and reach the LGBT community? And so at this point, Racquel, I don't know if you want to expand more on the mental health part, and then Samuel, you answer the Stephen Lewis Foundation partner question.
I think I should have Samuel answer that question. It's very important for this conversation. So go ahead, Samuel.
Okay.
You want me to answer about mental health or partnership?
I think you can incorporate both of them in your response.
Yeah, having a partner like Stephen, it's wonderful because I remember there was time we had COVID, and most of our staff actually were going through a lot of burnouts. There were a lot of violence, especially happening at that particular time. And we actually talked to Stephen Lewis Foundation about mental health. And actually they were able to help us actually even have an on-site psychological person or a social person who could be able to help the clients when they come. Because not only do clients want the HIV counseling, there is also the other part of mental health that necessarily require someone to be on site to be able to help, not even the clients only, but also our staff. Our staff work every day, and there was a lot of burnouts. Some of the that was very important, and we were able to even take our staff to a retreat to be able to talk about every issue that they were having. And trust me, after they came back, the production level went up. And when we are looking even at the client, the beneficiaries, at least they are able to tell a friend, like, can you go to MPEG? There is actually a support group. There is always a champion at the site to be able to talk about anything, not necessarily about HIV, but anything, because mental health, it goes all around. Like Racquel said about IPV, a lot of people, because of COVID, went home. And looking at the economic of most of our rural sites, or where we take even outreaches, when you go back home and people did not even see you before, now they are seeing you with your friends, your hands are like, or like this, then your mother starts asking you so many questions. And now you have suicidal thoughts, you're so stressed up, anxiety. There was opportunity for them to actually come and talk to someone at the site. That was excellent. And thank you so much, Stephen Lewis. That was good job. And for us, it shows us the partnership that we can be able to talk about issue. We were able even to scale up. One of the funders had a shift of the thematic area they were supporting. Stephen Lewis came on board and gave us the support to scale up some of the activities that we are doing from the previous funder. So for us and Stephen Lewis, we've been able to do a lot, and most of our beneficiary, even now, they're actually enjoying the site champions, the site psychosocial support that they are getting even now.
Thank you so much, Samuel. Racquel, again, your input, the sharing of information. It is one today, we remember those we have lost, but today we also celebrate their lives as individuals who we knew, who impacted us one way or the other. But today we also stand in solidarity with many communities globally that continue to fight this pandemic. It is not one we are out of the woods as we see numbers arising. And all of you have made some very valid points. And so as we're about to close off, we're gonna look at the major things of commitment, talking about government. Commitment needs to be more positive, needs to have funding, needs to take this roadmap forward and not backward, need to look at the decriminalization of the buggery law that hinders particular communities. We need to look at where prostitution or sex work is still a prohibited offense in the Constitution as well, because it affects our sex workers. We have other issues that are still criminalized as well, that in some parts of the world, we still need to unpack that. Where our Constitution itself, maybe the non-discrimination clauses can be open-ended, or at least inclusive of sexual orientation, gender identity, that allows for a response. We are asking our community-led organizations to be intentional about the work and the impact of the work that they're doing with grassroots community to ensure the impact is positive. You know, and one of the things that I like is that, and I heard it come out, the commitment, we are not doctors, but the doctors have one oath, which is to do no harm. And we as individuals, as community leaders, we are calling on all community leaders. We are calling on governments. We are calling on funders to help us continue creating programs that at the middle, the center of it, we continue to do no harm. So let's work. And I think, Racquel, you said that many times. Let's work better together. Happy World AIDS Day, everyone. And I'll pass it back over to Alan.
Thank you to all the panelists, and Kenita, thank you for wonderfully summing up the conversation. Just to echo, community-led organizations serving key populations continue to receive resources and funding inequitably. This needs to change. The progress we have made is still insufficient. I could not have thought of a more engaging and rich discussion to observe World AIDS Day today. The Stephen Lewis Foundation celebrates its 20 years anniversary of working with the community-led organizations this year. We thank you all who have joined us for your unwavering and continued support. Thank you, and have a wonderful day.